Thank you for the invitation to talk today. I'm Sreekanth Viswanathan. I'm a neonatologist and clinical researcher at Nemours Children's Hospital in Orlando, Florida. A brief background about me: I did my medical school in India, as well as pediatric residency, and I worked in UK for a few years, and then I moved to US in 2007. Did my residency and fellowship in Cleveland, Ohio. Spent my initial years as a faculty at Rainbow Babies and Children's Hospital in Cleveland and National Children's Hospital in Columbus, Ohio, before moving to Nemours in 2019. So I've been with Nemours for 6 years now. So as I said, I'm a clinical researcher, and my area of interest is infant nutrition, infant feeding disorders, and infant body composition. So I guess because the time is limited, I just want to talk about the NIH grant that we got it last year. So the title of the grant is Oral Feeding Difficulty in Large for Gestational Age Infants, defining interrelationship between body composition, oral feeding ability, and appetite regulating hormones. So this is a 3-year grant and came from NIDDK. It's a 2-center study. I'm the PI, the main PI at Nemours in Orlando, and my co-PI is Dr. McNeil at Emory University in Atlanta. My co-investigators include Dr. Babu Balagopal. So he is part of Nemours, and he's a director of biomedical analysis laboratory at Jacksonville, and Dr. Jessica Wu at Cincinnati Children, and she is an obesity researcher helping with our biostatistics. And my colleague, Dr. Chua, here at Nemours, and the study coordinator is Casey Mitchell at Nemours, and Nemours is acting as a single IRB for the study, and it was approved in August last year. So for a year now, we are actually recruiting patients into this trial. So when we started, when we set up the team to apply for this grant, what we did is we wrote a review article, and that was published in Pediatric Research in 2022. So this basically, I think, give us some credibility of our team that, so it actually it's also helped to, create the background application section of our grant. So why LGA? So LGA means large for gestational age infants. Babies with a birth weight that is more than 90th percentile for age. And if you look at the neonatology research world, most of the funding and most of the research is focused on the premature infants, especially the smaller premature infants, and there's not much focus on the big babies. So this is a relatively low-hanging fruit. And if you look at the population, the premature infants are about 10 to 12% of the total birth. And if you look at the LGA infants, it is also about 10%. So it's a similar size population, but very limited research being done on these patients. If you look at the epidemiology, the strongest risk factors for being born as an LGA is, maternal pre-pregnancy obesity and maternal weight gain during pregnancy. And if you look at the regional, survey data across the nation, about 40% women of the childbearing age are obese nowadays. And the risk of LGA increases by almost 7% for each kilogram weight gain. And this is also further contributed by gestational diabetes and type 2 diabetes, which is also increasing over the last 2 decades. So being born LGA is a significant risk factor for future obesity, and the reason for being born LGA is because they're exposed to excessive nutrition and high glucose diet, and that drives the fetal insulin secretion and drives the fetal overgrowth, and that often result in excessive fat, adipose tissue deposition. So there are several data that suggest that LGA infants, are at increased risk of childhood and adult obesity. So key message here is the recent data suggests that 10% of birth are LGA, and the number approaching that of infants who are born prematurely each year. So it's an increasing population of infants who are at high risk for future childhood obesity and cardiometabolic adverse outcomes. But if you look at our NICU nutritional practice, we just go by the weight gain trends. We want them to continuously gain weight, irrespective of their birth status. So all our nutritional protocols are, doesn't look at what is their in utero growth status. And if you look at the AAP guidelines, the recommendation is to provide about 90 to 135 calories per kilo per day of nutrition, which is equivalent to 140 to 200 ml per kilo per day of normal 20 calories per kilo ounce milk. But there are several data that suggest that if the babies gain rapid weight during the early part of infancy, that is associated with later obesity, and that is irrespective of the birth weight, irrespective of being LGA or not. For example, a BMI more than 85th percentile as early as 4 to 6 months of life increases the risk of severe obesity by almost 2.5-fold. So what happens to LGA infants in general? This is tracking the growth of LGA infants who are, relatively normal delivery and birth period and had a, breastfed completely, exclusively breastfed infants. So here is the graph showing the weight and length here. The black indicate the normal, appropriately grown, appropriate for gestational age infants, and the top one, the gray, indicate the LGA infants. And you can see that over the first 6 months of life, their growth normalizes, and by 6 months of age, the weights are comparable. So what that tells us that there is a deceleration of weight gain or a cash down growth in the LGA infants. So the hypothesis, the theory is it's probably because they have a deviation of growth in utero, and the body is trying to correct it postnatally. So again, the key message here is LGA infants, as a result of developmental programming in utero, are at an elevated risk of early childhood obesity, and this risk is further modified based on whether the weight gain accelerate or decelerate in the early childhood. So coming to the body composition, the simplest model of body composition, we call it as a two-compartment model, where you can divide the body into fat mass and the fat-free mass. The fat mass is is the energy store of the body, while the fat-free mass is the metabolically active tissue, which include all your organs, blood, bones, muscles, and rest everything except the fat. And now we have an FDA-approved device to measure the infant body composition. It's called the PPOD, and it's applicable to babies' weight between 1 to 8 kilos. So what basically, you measure the weight of the baby here, the mass of the baby, and then we put the baby inside a little chamber, and that measures the body volume. So once you have the mass and the volume, then you can calculate the body density, and then it has a formula to calculate based on the body density to calculate the fat mass and fat-free mass in babies. So this is a very easy, reliable technique, very validated against advanced body composition models, and it takes less than 5 minutes for the whole procedure. So why this is important? If you look at this is not specific to LGA infants, but in general, babies. This is a cohort study from Netherlands, and they used this PPOD to measure the body composition, and they found that any rapid increase in fat mass in the first 6 months of life are associated with adiposity at 2 years of age. So basically, they suggest that the first few months of postnatal life is a critical window for adiposity programming. And there are several birth cohort studies that suggest that LGA infants, when they are born, they have increased fat mass compared to AGA infants. So what happens once the baby is born? What happens longitudinally? Normal breastfed, healthy LGA infants, the longitudinal data suggests that their fat mass accrual actually slows down, and it approaches the normal fat mass to the AGA peers by 2 years. So the another point studies have noticed that because they have a higher percentage of body fat, they have a lower resting energy expenditure compared to healthy temperes. So that basically suggests that if you continue to provide excess calories above their metabolic demands, like the normal AGA infants, that actually can predispose them to future obesity. So our theories here is body fat trajectory in LGA infants can be a potential therapeutic target for nutritional interventions to modify the risk of obesity and related comorbidities. So the key message here is LGA infants who do not demonstrate a deceleration in weight or slowing of their fat mass accrual in the first few months of life are likely to be at higher risk of early obesity development. So why this is related to feeding, oral feeding. So many of the LGA infants kind of struggle with oral feeding, and that leads to increased length of stay. So this is one of the, not specific to LGA infants, but we looked at the body composition of infants who have trouble feeding and they are on term gestation. So here, for example, the white box plot is the the cases, that babies with trouble oral feeding, and the gray one are the controls who are on full oral feeding. And we can see that the patient who has trouble oral feeding has a higher percentage of body fat and lower percentage of fat-free mass. And so this is the right side, you can see the scatter plot showing the relationship between oral intake and the percentage of fat mass. And you can see that as the fat mass increases, the oral intake decreases. So what we think is possibly this may be contributed, by the different appetite regulating hormones, probably mediating this relationship. And there are several appetite regulating hormones, but basically, if you have a higher percentage of body fat, you have increased leptin, which is produced by the fat cells, and that is a satiety hormones, and that makes the babies, less hungry and less, easy satiety. Probably the reason why they are not very eager to eat. So what we are trying, so this is like an overview of our grant. So what we are trying to see is, we have two specific aims. Our first aim is to explore the interrelationship among these three variables in LGA infants. What is the relation between oral feeding, body composition, and appetite regulating hormones? And the way we are planning to study this, we are going to recruit 20 LGA controls who are on full oral feeding, and then compare them to 40 LGA infants with oral feeding difficulty. And we are going to do their PPOD at baseline, as well as check their appetite, 9 different hormones we are going to check and see how they are different. And the second part, specific aim is to do a pilot randomized controlled trial in babies who are troubled oral feeding. So it's a randomized controlled trial, and the intervention is, instead of using weight to calculate the nutrition, we use the body composition data, and we look at their fat-free mass alone and to calculate the feeding volume. So if they have a higher percentage of body fat, basically they have a lower percentage of fat-free mass, and so there'll be proportionately less nutritional intake. And then we compare to the standard feeding volume, and it's a 2 weeks intervention. And at the end of 2 weeks, we are going to check their PPOD to check for their body composition and check their appetite regulating hormones level. And we are expecting that, how this is impact their, primary outcome is time to full oral feeding, and how the body composition changes and how the appetite regulating hormone changes during this intervention. So that's pretty much, and so these are my collaborators and mentors, and just want to acknowledge here, and happy to take any questions.